this lecture because Dr. Shahani was one of my role models when we sort of at the same time in Leicester worked in, I think when I arrived there in 95, you just about also arrived there for a short stint. And I was amazed by, we were more or less the same age, but he came from Amrita with vast experience, and I just realized the vast numbers of cases people were doing here. And therefore, young people have got a lot of experience. And you could see from this morning's presentation of Dr. Amitabh Sen, and you know, the level of thinking and experience that people can present at that high standard. Now, since then, over the years, I've been to India regularly, and I've had the privilege of seeing the whole Indian ACTA grow. And people were in those days, the first time was 98 when I arrived here, and in those days, all of the presidents and the senior people from Indian ACTA were young and sort of same, we were all excited. But EACTA has contributed a lot, not only to the young people in this country, but I can tell you, to my own development, to development of other people around the world, all these invited speakers who come here, giving people an opportunity to come and develop and interact and practice. It just gives a sense of value and a sense of, yeah, just leave it. It'll be good. It'll be good. I'm going to just open. So, it'll open now. Sorry, it's taking a bit of time. Sometimes it doesn't recognize, but it'll come up now. So really, EACTA has done a great job, not only here, but also internationally. Let me do that. And we're going to open this, and then we're ready to go. So, I'm sure the next 3 days will be very exciting and a good interaction for everybody. For the young people who are learning, and for the senior people who are observing and guiding. And that is the way it should be. A society like this should guide people into, and the country will just get stronger. On at the moment at Grote Schuur Hospital, where they did the first heart transplant. And over the years, as I was visiting, this was in 2008, I think, with Nick Harvey and Justin Williams. This was the first Indian ACTA TOE course. And Dr. Hema and Dr. Koshi and Prabhat Tiwari and Dr. Murali, this was in Bangalore. So since then, the TOE course has come a long way. Chennai last year, wonderful to see many of the people again and to confirm friendships. We also took the opportunity to visit, and listen, India is leading the way. It's not only on an economical front, but also, I mean, hospitals, the world is looking up at a place like Narayana, and this morning I was talking to colleagues about their heart transplant programs. I mean, it's second to none in this world. That brings me to the topic, and apologies for the slow start, but in 1980, that was more or less the ratio of patients with congenital heart disease, pediatric to adult. If you look at 2000, and then what is predicted 2020, it's no doubt that young patients with congenital heart disease will grow up and will come back for non-cardiac operations. So what I'm going to concentrate on today is maybe the Gooch population. I mean, we can talk about neonates and primary operations, but that is a different story. We've only got 25 minutes. This morning we've heard about the embryologic development, and we should have a good understanding of that if we by any means want to be involved in perioperative echo. Now, Dr. From Brompton, there's no doubt that people have been looking at this. There are people who are paying attention. Dr. Bob Anderson and his colleagues who have run courses in morphology and embryology. If you're interested in this, make sure that you understand the development of the congenital heart. Now, from an echo point of view, long ago, Dr. Shane Wise have described the 20 views, and that is really the framework of starting off when you do congenital echo. It can be quite daunting in the operating theater if you don't have a clue what is wrong with this patient, but we're lucky. Our congenital cardiologists are very experienced echosonographers and hands-on, and therefore there's always a very good report. So the easiest place to learn perioperative echo in this, or TOE in this population, is to look in the operating theater where you've got time. You look in your report from the cardiologist and you go and search for the pathology. So it's really an easy way of learning. With that, you have the luxury of talking to the congenital surgeon, seeing the open chest and looking inside the chest. And therefore, you can discuss whether what you see on the screen is true. And that has been updated, those 20 views. So I use that, and I've extrapolated from my adult echocardiography practice into the congenital practice. Now, long time ago, Dr. Elliot Scheinborn, the Brompton again, has come up with this segmental analysis of congenital heart morphology and how we should go about when we analyze a congenital heart. And if we use this format, this framework in the operating theater, we cannot go wrong. So the first thing is we must identify whether what the atrial situs status is. Is it situs solitus or situs inversus? Is it isomerism of the right or the left side? Now what it means is, if you situs solitus, it means a morphological right atrium sits on the right side, and a morphological left atrium sits on the left side. And for that matter, inversus is the other way around. Isomerism is if you've got two right atrium, a right atrium on the right side and a right atrium on the left side. Or, for that matter, left isomerism, a left atrium on the right and a left on the left. Now, why is it, how can we recognize this? The atria has got a very specific morphology, and they differ. The right atrium is more pectinated. It's got a bigger auricle than the left side. And for that matter, we must remember that the bronchus, the bronchi and the lungs always accompany the atria. So if you've got two left atria, you'll have two left lungs, one on the left, one on the right. And for that matter, the abdominal contents follows. So it can become quite complex when we get lost in this sort of hodgepodge of crisscross. That's an example. Now, how it can trick you. It appears to be a normal 4-chamber mid-esophageal view. This patient came for a redo of a mitral repair. Now, the only catch there is that actually, you look at that icon, it's at 180 degrees. So you find that this patient has got dextrocardia. So we must always take into consideration all the information on our echo screen. Now, the next one of our segmental analysis steps is where we look for the connection between the atria and the ventricle. Now, normally it would be a tricuspid and a mitral valve. Well, we must remember that the valves, the atrioventricular valves, always go with the ventricles. So a tricuspid valve will always be connected to a right ventricle, whether it's on the right or the left side, depending on how we've got discordance, concordance. Now, this is a new terminology we're learning now. It's like learning a new language. And concordance means a right atrium through a tricuspid valve into a right ventricle. Discordance would be right atrium through a mitral valve into a left ventricle. Now we start to it becomes a little bit more confusing. So we talk about concordance and discordance when we talk about transposition of the great arteries. Then we also look at the morphology of the atrioventricular valves. Now, a right ventricle, we must know and understand that it's morphologically different from a left ventricle. A right ventricle has got a moderator band where you would expect the right bundle branch to run through, while a left ventricle won't have it. A right ventricle will have a tricuspid valve which has got 3 cusps, and one of them connected to the septum. Well, The left ventricle has got a mitral valve with nothing connected to the septum. The valve leaflets are connected to the papillary muscles, and therefore we can now identify the two ventricles and see whether they are in the right place. Right ventricle also has an inlet area, a trabeculated apex, and an outlet. Now, the next step would be to look for ventricular arterial concordance or connections. So is it the left ventricle connected to the aorta, or is it maybe, as in transposition, connected to the pulmonary artery? Important to make sure that we identify the morphologic structures when we're dealing with congenital echocardiography. Of course, the valves itself must work, and then the great arteries will have a look. This is an example of a 15-year-old patient. We heard about tetralogy this morning, tetralogy of Fallot, and this patient now, as they do after a tetralogy repair and a transannular patch or a transannular incision, to open up that stenosis as in childhood. Now the child has grown up, and now this patient needs something, because there's free flow, red and blue across that right ventricular outflow tract. So this right ventricle can cope for it for a short while, but then it also starts to dilate. So in this case, nowadays with a Melody valve, and I don't know which units are using them here, but people can do it percutaneously. It is, however, expensive and not always readily available in all hospitals. And with 3D, we just appreciate the vast sort of space that has been created as the child grew up and the ventricles started to dilate, the right ventricular outflow tract. Now, other problems with the outflow tract can be obstruction of, say, for instance, this case, the left ventricular outflow tract. This is an example of a subaortic membrane, which is, in this case, appears on two-dimensional echo as a little membrane there. But it's actually a three-dimensional structure which sort of can occlude and create turbulence all along the outflow tract. And in this case, the turbulence starts proximal to the aortic valve in the outflow tract with a very prominent interventricular septum, eccentric hypertrophy there. We must always look for associated malformations or abnormalities. This patient came with a bicuspid aortic valve, but the valve is actually working all right. It's a young patient, about 12 years old, and there's no obstruction. This patient may have problems later in life with calcification early of this valve. However, why is coming for an operation is here I've turned down the depth, and we are in the long axis, and this is the descending aorta with the head of the patient on the right side and the feet on the left side, and therefore this little very, very tight obstruction in the descending aorta. So it is we must always look for associated problems. I'm going to concentrate a little bit on shunts on the atrial level. We have a different presentation later today actually on shunts and bands, which will not overlap too much. But all of these are examples of how there can be shunting on an atrial level. Now, this is not the only focus of this discussion, but let me show you a few examples. Ostium secundum ASD, and when we say this patient has got a left to right shunt, we say the left atrium is enlarged with a septum bulging, and the right side, and there's blue. So blue means flow away from your transducer at the top, and therefore left to right flow. Now, usually with this goes a right atrial, right chamber volume overload. So the right atrium will enlarge, the right ventricle will enlarge, and one can measure the diameter of that opening. But we must understand that a secundum ASD, which is there in the secundum septum, of course, is a deficit. It's not always round. It can be oval shaped, like in this specific case. So when a cardiologist wants to close it with a Amplatz device and we make our measurements, we must be aware that we must measure it in all diameters, both long and short axis. And guidance with 3D echo can help to guide the the introducer across this deficit, and then the placement of the Amplatz device, which makes very nice pictures on this X-plane view, and we realize now, we can confirm that this device is solidly seated there. There are different parameters we're looking at to identify, and the cardiologists usually appreciate very much our input in the cath lab. Really a place to learn congenital heart disease is in the congenital cath lab, because that's where you can interact and discuss and learn all the new pathologies. And we talk about the aortic rim or the superior rim and the inferior rim and make sure that that is confirmed. The cherry on the cake is when you can make a nice pictures like this with 3D echo and turn it around, and everybody is very excited when they see this, because this is really your show and tell picture. Now, sometimes there's more than one opening across the ASD. Like in this case, where it's really, really big, and we have to maybe use more than one Amplatz device in this case. And yeah, it is an expensive way of treating. This surgeon can do minimally invasive very quickly, and the patient can be out of the operating theater. So it is really a luxury type of procedure when you can put more than one or two Amplatz devices into holes. Sometimes things go wrong, and this specific patient came from the cath lab quite in trouble. And the surgeons will smile and the cardiologists will be embarrassed because they've lost this device. It's been dislodged because of some of the rims of that opening not being sort of securing the device and into the outflow tract of the right side, and therefore really obstruction in a patient who is in big trouble. Now, sometimes we cannot avoid a surgical repair. Like here, we've got a perforated secundum septum. Many different holes. And you have to then take the patient to the operating theater. It's nice to confirm intraoperatively that there is a good closure. This 36-year-old male patient came for a surgical closure of a secundum ASD. Now, it's a bicaval, almost a bicaval view with the SVC on the right side, IVC on the left side, and your right atrial appendage at the bottom. And you just look, and it's not that clear, the secundum opening. And then we realized, but actually, this was a bit of a misdiagnosis. It's not good. And was referred to an adult surgeon, not a congenital surgeon, and we then have to get help because this is actually a patient with a septum primum ASD. And that's confirmed by the lack of offset of the tricuspid valve, or for that matter, the atrioventricular valve on the right side. Usually that's your more inferior valve. But in this case, there is no offset and a huge opening, almost a common atrium there. And we had to call on the congenital surgeon to come and help. And often, as it does with these septum primum ASDs, there's a cleft, and very nicely described this morning, a cleft on the left-sided atrioventricular valve, and the surgeon will have to repair that at the same time. Another example of a septum primum, very clearly and with flow from the left atrium going into the hugely dilated right ventricle, straight from the left atrium and a left to right shunt. Now, we can look at it from all different angles, and if you look at this picture where actually this is a partial atrioventricular canal. It's an atrioventricular canal with only an atrial component, and there are different variations of this. In other words, one can have a true atrioventricular canal where both on atrium and ventricular level they are opening, or just with a VSD. And in all of this, you've got a single annulus of the atrioventricular valve. One valve stretching over across both ventricles, and we don't talk about a mitral and a tricuspid valve in this case. Now, in this specific patient, this next one, sometimes you get a different variation. So this is an atrioventricular canal with no shunt across. The only problem with this patient, it's got a cleft, and the jet will come, if you look there. This doesn't look normal, this mid-esophageal 4-chamber view, obviously with high pressure on the right side, with a septum bulging across to the left, and a bit of hypertrophy on the right side. And if we assess what we would have called a mitral valve, we now talk about a cleft mitral. It's actually a left-sided atrioventricular valve, which is incomplete, and therefore this strangely looking jet. And often you have to recognize the pattern. It's sometimes difficult to say, what is the reason, the mechanism of this, if you may, mitral valve repair, mitral valve regurgitation, until you start to examine it more clearly. And a transgastric view will show you this, an interruption of where was supposed to be an anterior leaflet. Actually, a superior and inferior bridging leaflets we talk about now. And on 3D, it becomes much more clear, and the surgeon now has to close up that cleft, and they're always scared to make it too tight. So you always find that there's a little bit of residual regurgitation across this valve. And afterwards, maybe a correction like this. So if we then look at sinus venosus ASDs, there are different variations, and this is a superior sinus venosus ASD. Again, because the shunt is on atrial level, a lot of blood going through the lungs and through the right atrium and right ventricle. Hugely dilated, moderator band clearly visible. And with 3D, it's not like it gives you that much extra information, except that you can appreciate the moderator band and the dilated right side much better. Now, if we look at the bicaval view, then where the SVC was supposed to come in, and the cresta terminalis right atrial appendage, the interruption, the connection between left and right atrium, then one can understand why this is often accompanied by partial anomalous pulmonary venous drainage. In other words, the right upper, usually, pulmonary vein will drain into the right side and therefore give increased flow across through the lungs. So one can actually clearly see it here with a 3D picture where it doesn't show on the screen there, but the right upper pulmonary vein coming in there and therefore draining in both directions. But because the pressure will be lower on the right side before it reverses, that is where the blood will preferentially go. Now, with color on, you understand why people talk about the pulmonary veins draining then on the right side, and in this case it can give you problems and therefore needs correction. And afterwards, confirmation that the right upper pulmonary vein is redirected towards the left side nicely and flow going in there and nothing to the right atrium. Now, this is one of my big hits in my career. We're a 64-year-old female, very well investigated by an adult cardiologist, and the patient came for mitral regurgitation and tricuspid regurgitation. Patient had an ASD closure 45 years ago by Sir Magdi Yaqub, and now getting short of breath. Very symptomatic. And when I looked at the heart, I said, why is the right side so big? It doesn't show severe pulmonary hypertension here, but why is the right side so big? And the septum bulging across to the left. And it does not correlate very nicely with this, what I would say, moderate mitral regurgitation. And the tricuspid valve, yes, it's leaking, so obviously there's a high pressure. I can read off the screen there, 20 millimeters mercury, plus say at the most 20 would be 40 millimeters mercury, the systolic PA pressure, or less than that. So yes, it's high, but that doesn't explain the huge right side. But then at closer look, I identified the inferior sinus venosus ASD. Very easy to miss, unless you advance your transducer and you look where the liver is, transgastric, and you withdraw a little bit. Remember that only 1 or 2 centimeters of the IVC is in the abdomen. Most of it, in the chest. Everything else is in the abdomen. And then the direction of flow from left atrium to right atrium on this inferior sinus venosus ASD, which then, after repair of the tricuspid valve and mitral valve and the ASD repair, the patient is happy and so she was walking around with this lesion for most of her life, or all of her life, actually. Now, then other lesions, valvular lesions, we have to know about, and I'm now speeding up a bit. My time is almost up. We get different variations of aortic valve, this case a quadricuspid valve. We get unicuspid valves, but certainly the poor coaptation is visible of these 4 leaflets, and one understand why there's quite severe aortic regurgitation. And with 3-dimensional echo, one can use this data set and just turn it around, look at it from the aorta side and from the ventricular side, and understand the function of these valves and what the surgeon can plan their operation procedure much better. So 3D echo, I find, is a very good tool to communicate, to explain, and to interact in the operating theater. And even the nurses who haven't got much training in this type of pathology will understand when you show them. Epstein anomaly is when the tricuspid valve, of course, is displaced anterior and superior. Why? It took me a while to understand why anterior. Because you've got an inlet, a trabeculated apex, and an outlet area. So if that valve the anterior valve is large, and the hinge point's actually at the normal position. But then the septal and inferior leaflets are brought around and superior. And therefore, we talk about atrialization of the right ventricle. And we must remember this muscular shelf. The myocardium is not normal. That's often visible with a leaflet, the big right atrium, or atrialization, with the inferior and septal leaflets displaced into the outflow tract. Of course, the valve is not competent, and this is not just for a valve replacement or for an easy repair by a non-congenital surgeon. These can be very complex repairs and needs experience. Often, this is, or in 80-90% of cases, there's an interatrial communication, and ASD therefore also needs closure. We've had a lecture on Fontan. I'm not going to do that again, but we know the different stages. We've been told about the BT shunt first, the Glenn shunt, and then the completion of the Fontan at different stages of the patient's life. And by year 6, 7, the patient's already on their 3rd or 4th operation. So not really a good, the single ventricle organization. My time is up. Just an example of this type of patient who has turned 20. Now, after several operations for a hysterectomy because of bleeding, a lateral tunnel Fontan many years before, and now gynae bleeding and anemia. And at the end of the day, what I want to say here is this was for a non-cardiac procedure. The echo is a good monitor. It's not for me to make the diagnosis and pick up the patient's diagnosis in the operating theater. It is to guide the patient through a difficult operation where with a Fontan you don't want to inflate the abdomen for too much, too high pressures. It affects your venous return. Your spontaneous ventilation versus positive pressure ventilation, PEEP, and so on, positioning. All of this will have effect. And we can monitor the patient, and not only the ventricle, but also flow across the valves. Thank you very much.